Hi everyone, thank you for that kind introduction. I'd like to thank Zachariah and the sponsors for this invitation to present at the first UAE Movement Disorder Virtual Conference. I have no conflicts of interest in this educational presentation. The objectives of this presentation are to gain an insight into the spectrum of movement disorders, and in particular to recognize the different types, be able to localize areas of pathology, and also gain an insight into the treatment modalities that are available. This overview shows the two main feedback loops that modulate the signals coming down from the motor cortex down the pyramidal pathways, and that modulate our movements. So the basal ganglia loops and the cerebellar loops. The motor cortex basal ganglia thalamus loop controls the speed of movements, and the motor cortex cerebellum thalamus loop ensures smooth and coordinated movements. As you can see, both loops flow through the thalamus. This coronal image shows the additional inputs from the substantia nigra and the subthalamic nucleus into the basal ganglia loop. And this slide shows at what levels these loops interact with the pyramidal pathway signals. Now, this is an overview of motor and movement disorders, and this talk we will be covering the hypokinetic and hyperkinetic extrapyramidal disorders, cerebellar disorders, and some miscellaneous conditions such as akathisia. And it's useful to consider this kind of overview because it also helps determine what kind of medications work. Dopaminergic agents such as levodopa or direct dopamine agonists are effective in the hypokinetic disorders such as Parkinson's disease, but are also useful in the rubral or red nucleus tremors. Anticholinergic medications are also effective in these disorders, but also work in dystonias. And finally, the more pronounced hyperkinetic disorders such as bulismus, chorea, athetosis, as well as tics, respond to antidopaminergic agents because it's considered these disorders are related to excess dopaminergic activity. Starting off with tremors, these are rhythmic oscillating movements, and we recognize three basic types of tremor. We'll start with postural tremors, which occur during voluntarily maintained postures. Rest tremors we're all familiar with and are due to disturbances in basal ganglia dopaminergic pathways, such as in Parkinson's disease. And then there are the action tremors, which occur during target-directed movements, increasing in amplitude as the target is approached. We demonstrate these with the finger, nose, and heel shin tests, and they're due to disturbances in cerebellar function. We screen for postural tremors by asking the patient to point their index fingers at each other under their nose, with their shoulders abducted to 90 degrees and their elbows flexed. With the distal positional tremors, most of the oscillatory movements will occur at the fingertips, with little in the way of oscillations at the shoulders. With the proximal positional tremors, as it occurs typically in Wilson's disease, you'll see more of the movements at the shoulders, resulting in the kind of bat's wing or wing beating tremor that's characteristic of this condition.
Okay, now up under your nose, but don't touch. Both hands, yep. Try not to touch, that's good. Okay, nose.
Okay.
Backwards and forwards. Okay, in this hand.
The left hand were.
Okay, take it with both.
There's no way I can do it.
Okay.
The first-line treatments are generally considered to be beta blockers such as propranolol and primidone, and second-line agents include clonazepam, gabapentin, topiramate, and the carbonic anhydrase inhibitor methazolamide. I must say, nowadays we will probably elevate topiramate into a first-line therapy. So typically, I would start off with a beta blocker such as propranolol, and then add topiramate next, and reserve primidone until the third line, the third agent, because especially in this country, it's a controlled agent. For the essential tremors, you can use Botox therapy, and for the very severe tremors, you can consider surgery. particularly thalamotomy. Nowadays, we tend not to do thalamotomy as much because we have a DBS or deep brain stimulation, and the target will be the ventral intermediate nucleus of the thalamus. But even DBS can be considered slightly invasive because you need a burr hole to get through the skull, and then the electrode itself will go through brain tissue before it reaches the target. And nowadays we do have less invasive modalities such as focused ultrasound and radiosurgery with the gamma knife.
This patient with Wilson's disease displays a very characteristic wing-beating tremor of both upper extremities. This patient with tremor-dominant Parkinson's disease displays a very large amplitude resting tremor of her left upper extremity. With her arms elevated after a period of several seconds, she develops a re-emergent tremor of similar type in the left arm. Resting tremor of her left hand. This patient exhibits a kinetic or action tremor in both upper extremities during chin-finger testing, with larger amplitude limb oscillations as he approaches the target of the examiner's finger or his chin. There is also a component of mild dysmetria. This patient with Holmes midbrain tremor is displaying a severe large amplitude postural tremor of his left upper extremity. Not shown here is an equally severe tremor at rest as well as kinetic tremor with finger-nose testing. Clip 2 again shows a severe postural tremor. He's being asked to touch an object and then touch his chin, but is unable to do so.
So we've done the tremors. We'll come on to the kind of hyperkinetic disorders extending from myoclonus, valismus, chorea, athetosis, dystonia, and also tics. And as you go from left to right, the movements become less violent and explosive and jerky into more smooth and flowing movements. So by the time you come to dystonia, they're more sustained muscle contractions. And the first 5 conditions on the left, they can be considered to be different from tics, in that tics can be suppressed by voluntary control for a short period, whereas these other conditions can't. And the spectrum from valismus to dystonia should be thought of as really a spectrum, not as separate entities, and they just become less violent as you go more towards the right. And they're all generally considered, except myoclonus, to be due to excessive dopaminergic activity. So the therapies are targeted at anti-dopaminergic effects. Myoclonus, these are sudden shock-like movements. And I always tell students and trainees that for myoclonus, if it looks like as if the patient is receiving electric shocks, then that's likely to be myoclonus. Most cases are due to positive myoclonus, i.e. due to active muscle contractions, but there is a special form that you're probably familiar with of negative myoclonus, as occurs in liver failure. It's referred to as asterixis, with movements due to loss of muscle tone. Here's a clip of myoclonus. As you can see, it looks like the patient could be receiving little electric shocks to cause these movements. And myoclonus can be further categorized into epileptic or non-epileptic, and cortical and subcortical types of myoclonus. Generally, if it's more cortical, it's likely to be more potentially epileptogenic. And the treatment of choice is of valproic acid and also additional use of clonazepam. On to valismus. It's derived from the Greek word valismos, which means jumping about or dancing. And valismus is defined as a continuous, violent, coordinated, involuntary activity involving the axial and proximal muscles, such that the limbs are flung about. And usually it's one-sided and is known as hemivalismus, but occasionally you can get bilateral movements, which is bivalismus, or if it's 2 upper limbs or 2 lower limbs, you can refer to it as paravalismus, and can be considered a more severe form of chorea.
Vaginism is an involuntary movement disorder affecting one half of the body. It usually results from cerebrovascular accidents involving subthalamic nucleus. It is characterized by sudden flailing, intense and violent movements.
And typically caused by a lesion in the subthalamic nucleus, and it's usually a vascular event. And the second most commonest cause of bulismus that we see is when we overdose a Parkinson's patient with too much levodopa, so you can get bulismic movements there. And generally the treatment for bulismus is dopamine antagonist therapies such as haloperidol or chlorpromazine. Chorea, it's from the word, a Greek word meaning a choral dance, and it's irregular time, non-repetitive, randomly distributed, spontaneous movements. And they can vary from restlessness to fidgety movements to more dance-like gaits, or in the severe forms, a continuous flow of disabling violent movements. And the patients will show motor impersistence, i.e. they cannot maintain a sustained posture. And so when you ask the patient to grip your fingers, you'll be able to demonstrate the milkmaid's grip, which we'll see on the video coming up. And also when they try and protrude the tongue, they can't maintain a tongue protrusion, so the tongue will keep popping in and out. And that's variously alluded to as flycatcher, trombone, harlequins, or jack-in-the-box tongue. And the patients sometimes try to master chorea by augmenting the movements into semi-purposeful movements.
So this patient sitting on a bed exhibits fairly continuous, irregular choreiform movements of her extremities. Again, the choreiform movements are evident with her arms held outstretched in front of her, somewhat exaggerated in this position, and also involving the right more than left upper extremity.
Here's the milkmaid sign. Patients asked to grip the examiner's fingers, and it feels like it's a milking action.
She has difficulty maintaining a grip on the examiner's fingers.
This 59-year-old woman with Huntington's disease has a 7-year history of chorea, gait difficulty, and postural instability. She also has marked motor impersistence demonstrated by her inability to maintain tongue protrusion.
Andreas, I just want you to stick your tongue out and try to hold it out. Now hold it out as long as you can. Okay, now move the tongue to the right.
And the lesions in chorea can be the putamen, globus pallidus, or the subthalamic nucleus. And the treatment is basically towards dopamine depletion with agents such as tetrabenazine or dopamine antagonist therapies such as haloperidol or chlorpromazine. Athetosis is from the Greek word meaning not fixed, and it results in a slow writhing movements like squirming, twisting, snake-like or worm-like movements. Chorea-athetosis is a term as an intermediate form from the it's more rapid than athetosis but slower than chorea, so it's a mixture of chorea and athetosis. And the only real difference between chorea-athetosis and athetosis is the speed of movement. So as I referred to above, it should be considered a spectrum disorder, these movements. Athetoid cerebral palsy is where there's damage in the infant due to excess bilirubin. And the condition is kernicterus, where there's damage to the basal ganglia. You can see the slow writhing movements, snake-like.
No.
Dystonia is from the Greek meaning altered muscle tone, and it refers to sustained or spasmodic muscle contractions involving co-contraction of agonist and antagonist muscles, and they're resulting in movements that are slow and sustained and often frequent abnormal posturing and twisting, which can be painful. And we can categorize them into focal, where only one body part is affected. For example, in the face, if it's the eye, it's blepharospasm, or around the mouth, oromandibular dystonia. The neck, spasmodic torticollis, and limb task-specific dystonia such as writer's cramp. When 2 or more adjacent body regions are affected, it's a segmental myotonia such as Mej syndrome, where there's the eye affected, i.e. blepharospasm, as well as oromandibular dystonia occurring together. When 2 or more non-adjacent body regions are affected, it's multifocal dystonia, and generalizes where the trunk and 2 other body regions are affected. So here's the focal dystonia affecting the neck, spasmodic torticollis or wry neck. To begin with, you can see overactivity of the left sternomastoid such that the head is turned to the right and tilted upwards. And sometimes you do get overactivity on the right side as well, resulting in the head turning to the left. Here's the focal dystonia in the limb, the writer's cramp.
This patient is attempting to write with her dominant right hand. While doing so, she immediately develops a severe flexion dystonia at the wrist with wrist flexion and excessive flexion of her thumb and fingers. There's also some ipsilateral overflow to the elbow and shoulder region.
And here's the case of Mej syndrome.
This individual displays what might be called Mej syndrome. It's a combination of very prominent and forceful blepharospasm as well as lower facial dyskinesias, and is in many such cases associated with significant anterocollis. She's using a sensory trick of attempting to get her eyes open simply by placing her hand on her forehead, which is not terribly effective. Sometimes she tries to passively elevate her lids with her finger.
So the proper present pronunciation is Mej, after Henri Mej, the neurologist, has described the condition, but some people just pronounce it as Meek syndrome, so that's fine as well. And here's the generalized dystonia.
Jetzt eine Möglichkeit mit einer Bewegung, die Sie machen, dass Sie etwas besser in die Aufrichtung kommen. Können Sie mal aufstehen? Können Sie sich mal umdrehen?
So can you see in that particular video, it's how disabling that can be. It's very twisted postures resulting. Treatment of dystonia, the anticholinergics such as trihexyphenidyl, some antihistamines such as diphenhydramine are also effective, and then the muscle relaxants such as diazepam and baclofen. If you have focal dystonias, they often respond well to Botox, for example, in spasmodic torticollis or blepharospasm. Botox is probably the best option. And very important point, any patient with a childhood onset dystonia should always receive a levodopa trial to rule out dopa-responsive dystonia, because DRD is exquisitely sensitive and responsive to levodopa, and it's important not to miss that diagnosis. For the severe cases like that video of the generalized dystonia, you can consider thalamotomies or pallidotomies, but these surgeries are rarely used now that we have DBS or deep brain stimulation, and it's a globus pallidus interna that's the target. But we can also consider less invasive therapies such as focused ultrasound or gamma knife now. Brief, recurrent, jerky, non-rhythmic, stereotyped, seemingly purposeless movements known as motor tics or sounds, which are vocal tics. And it's usually preceded by an uncomfortable feeling or sensory urge that is relieved by carrying out the movement. And typically tics are worse under stress. And they're distinguished from the other involuntary movements that we discussed by the ability of the patient to voluntarily suppress their occurrence, at least for a short time. But after a period of trying to suppress, it does become uncomfortable for the patient, and it becomes that discomfort is relieved by letting out the tic. They can classify them into motor or vocal, simple or complex. Simple motor tics include hand clapping, neck stretching, mouth movements, facial grimacing. Simple vocal tics are things like sniffing, grunting, or throat clearing. Complex motor tics involve things like pulling up clothes, touching other people or objects. Echopraxia, which is repeating or imitating another person's actions. And copropraxia, which is involuntarily performing obscene or forbidden gestures. Complex vocal tics can manifest as echolalia, which is repeating words just spoken out by someone else. Pallilalia, which is repeating one's own previously spoken words. and more disabling will be coprolalia, which is the spontaneous utterance of socially objectionable or taboo words or phrases.
This patient exhibits
Example
a
for
series of
complex
complex motor tics which consist of sequential head shaking and head turning, shaking of his arm, kicking of his leg, all of which occur together with grunting and humming noises and repeating it over and over again the last syllable of a word.
And severe end of tics disorders is Tourette's syndrome, which can be inherited as also. Tics and Tourette's syndrome, it can be considered as a kind of overlap with ADHD, obsessive compulsive disorders, and behavioral problems. And all these conditions are thought to be due to overactivity of dopaminergic pathways. So for treatment of tics, you'll be going towards dopamine receptor blocking with agents such as haloperidol or dopamine depleting drugs such as tetrabenazine. You can sometimes get benefit from other agents such as clonidine, guanfacine, which is an alpha-2 agonist, or with benzodiazepines. DBS has been used for severe case of Tourette's syndrome with 4 different targets that have been tried, 2 in the thalamus and 2 in the GPI, and all 4 targets seem to be equally effective. So we've covered these various movement disorders. Coming on to the miscellaneous group, particularly akathisia. So this is basically a motor restlessness with a desire to move, and the patient describes it as if they're always crawling out of their skin, and can be associated with vocalizations and grunting, and can be disabling. And it's caused by neuroleptic drugs such as antipsychotics and also metoclopramide. Tardive dyskinesia occurs weeks but generally years after exposure to dopamine receptor blocking drugs, typically the neuroleptics, and results in involuntary movements such as facial grimacing, chewing movements, or tongue movements. It's the oral buccal mandibular area. This video shows a tardive dyskinesia, and in particular the eyes that can be severely affected with eyelid spasms so strong that the patient can't even open their eyes. It's thought to be due to hypersensitivity of dopamine pathways after this prolonged blocking by these medicines that we discussed. And generally, the mild cases are up to a third of all tardive dyskinesias can disappear with time, but the more severe cases, and about 2/3 of all tardive dyskinesias, remain permanent. And the treatment is general withdrawal of the causative drug, but just be aware that withdrawal can often initially worsen the symptoms. Then dopamine depletion with things like tetrabenazine and reserpine. And in 2017, valbenazine received an FDA approval for use in tardive dyskinesia. The overview we went through, and I think we'll be coming on to the MCQ videos next. Thank you.